well and things. Oh,
Okay. Oh, someone will present a different conflict of interest before. Is that correct?
not in this topic area, but we have quarterly webinars like this.
Okay.
So
Okay.
So the conflict of interest for the entire program comes up in these slides that are running right now. So you and Brian will just need to state your personal conflicts of interest.
Okay, good. Oh, I can see you, Jane, but can you see me?
Yes, absolutely.
Okay, I can't see me. Okay, good, perfect.
And so we will have question and answer available. So if attendees have questions that come up as during the presentation, if you will put those into the Q&A pod, we will make sure that they get answered as many as we can. And if you have any technical issues with not being able to hear or anything like that, please put that in the chat so that we can try to handle that.
Good. Hi, Sarah. Finally, I can see you.
Yes, I didn't turn my camera on right away. All right, we're going to go ahead and get started. Welcome, everyone. My name is Sarah Meanrod. I am the PBRN coordinator with DO-Touch.NET. Thank you all for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, we just have some housekeeping rules. Jane just kind of went over those, but I'm going to go a little more in depth. So if you could please add your name and location into the chat to the all panelists and attendees so that all the participants can see who's attending the webinar. If you are requesting CME, you need to make sure you add your name, otherwise we can't count your CME. Also, if you're requesting CME, we need you to fill out the physician attestation form, which I sent you this morning, and the evaluation survey for today's webinar, which I will send you this afternoon. Just so you know, the planning committee for Let's Talk About OMM Research has no conflicts of interest to disclose. If you have any technical issues during the webinar, please send a message to all panelists in the chat and we will address it. If you have any questions or comments during the presentation, please feel free to type them in the Q&A pod. Please feel free to address each other's questions and comments there as well. After the presentation, we'll have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and I will unmute you and we ask that you briefly introduce yourself and then also limit your time to 3 minutes so we can make sure to get everybody's questions and comments in. Also, please keep in mind that this webinar is going to be published to the DO-Touch.NET website and YouTube for further discussion, and we will send you an email letting you know that it's there and ready for you to discuss there as well. Please help us welcome Rafael Zegarra-Parodi. He is a registered osteopath in France and the United Kingdom, co-founder and CEO of the BMS Formation in Paris, a research affiliate of AT Still Research Institute, executive committee member of DO-Touch.NET, associate editor of International Journal of Osteopathic Medicine, and a member of the board of trustees for the nonprofit foundation Comey Collaboration. Rafael will be speaking about the clinical relevance of the body, mind, spirit, and osteopathic tenet in contemporary osteopathic care. Rafael, the floor is yours.
Thank you very much, Sarah, for this kind introduction. So I'm going to share my screen. So, and hopefully you can all see the first slide of this presentation. So thank you again for this kind invitation and for this wonderful opportunity for us to talk about this body, mind, spirit osteopathic tenet. It has been my main area of interest over the past 2 years. And I'm very happy to share with you our different thoughts. We probably have more questions than answers, and hopefully the Q&A session will be very interesting for all of us. So probably, yeah, if you have a look at this picture, one other conflict of interest that Sarah did not mention is that I have 2 different nationalities. I am French and I am Peruvian. So I can understand 2 different environments. In France, here in Paris, and in the US, when I spent 2 years with you guys at ITSU, I had my scientific Western mind. And when I'm in the Peruvian rainforest with my friends, I can say that I have more complementary and alternative medicine mind. So facts can be perceived and can be interpreted in different ways depending on our belief. And this is the basis of my thoughts about this body, mind, spirit, osteopathic tenet. So let's start. So those are the conflict of interest. I have nothing to add. Those are Brian. If it's okay for you, I can move on, or unless you want to add something. So yes, we haven't seen each other for more than 1 year. Last time I went to Kerrsville was 2 years ago, so nothing to disclose here. So let's have a look all together about the plan. Hopefully you will be able to critically appraise current traditional body-centered models for osteopathic care and reflect on different opportunities already available to develop more evidence-informed, person-centered models for osteopathic care. Then we will be able to critically appraise the relevance of this body, mind, spirit osteopathic tenet that has been reintroduced in 2002, but lacks of clear definition and is not clearly associated with any clinical practice. Given current neuroscience models of bodily perceptions and pain. So there's a lot of materials that I could share with you. We have a very limited period of time. 1 hour is short, but I'm going to give you all the different papers we have used, and all the references are available, so you can make your own comments about this current tenet. And at the end of this presentation, we're going to share with you how you can reflect on your own osteopathic practice and with possible sociocultural health assumptions. Like I said, we have described 2 different ways of perceive things, of interpret things, from that ranges from Western to complementary and alternative medicine, sociocultural health assumptions. And most of the time we think about us as practitioners. And what I would like to emphasize is to put the patient first and try to avoid to make assumptions that because a patient comes to visit us, he has the same assumption about how he or she can interpret his symptoms, what really disease and health means for each person. So this really depends on his environment. So I've missed this one. So first, a couple of slides to describe the different existing contexts in osteopathic medicine and osteopathy. So basically, I'm going to talk about 3 different environments that I know. So osteopathic medicine in the US, osteopathy in the UK. So the US is the only country in the world where osteopathic medicine is a medical profession. In the UK, it's an allied health profession. And here in France, I'm in Paris currently, it's a professional title. So it's not an healthcare profession. So as I've said, we're going to discuss the different models existing, and those are and some are currently challenged. So this one is just to emphasize that in the US, you guys, the clinical guidelines for treating patients with low back pain relies on the detection and the treatment of somatic dysfunction. This is what we call the body-centered approaches, meaning that the practitioner is evaluating the clinical sign associated with somatic dysfunction, and then starts to build his treatment based on his or her diagnosis. Here in France, we have a similar legal definition for osteopathic practice. It's based on what we call osteopathic dysfunction. Again, it's a body-centered model where this is the osteopath that is who is treating somatic dysfunction, trying to decrease symptoms and promote health. Here in France, we don't have a clear definition of osteopathic technique. It's a set of gestures based on osteopathic principles, and osteopathic principles are not legally defined in France. So it's quite unclear. If we have a look at the osteopathic principles, just a very quick overview to say that A.T. Still himself never defined osteopathic principles. It's only after he died that for educational purposes, a group of people started to create those, define those osteopathic principles in order to organize education and training. And the first principles were established in 1922 by Louisa Burns, if I'm correct, from the ATST Research Institute. So, and those principles were updated in 1953. And the last update was done in 2002. What I have highlighted here is that the topic, the target for treatment. In the 1953 principle, it's the body. And in the 2002 principle, the main target for treatment is a person. And here we can see one osteopathic tenet. So each person is the product of dynamic interaction between body, mind, and spirit. But again, this is not clearly defined. So here in France, those osteopathic principles and foundation have to be critically appraised based on the best available evidence. And this is exactly the same in the UK, where I'm, as just Sarah pointed out, I'm registered there too. And I have to use the best available evidence. It's an ethical duty to help my patients by using the best available evidence. So that's a problem. At least that's something that we have seen, that it's very difficult in those body-centered models to distinguish what an osteopath can do, what a chiropractor can do, what a physical therapist can do. So if it's very difficult to define a profession through his manual technique. If we have a look at the best available evidence, like I said, something I have to do as a French and as a registered osteopath in France and in the UK, we can easily look at in this systematic review and meta-analysis that was published 2 years ago, that authors haven't found any differences between manipulations and placebo. However, there were some methodological flaws, and it was kind of difficult to sustain this conclusion, because they required additional studies with appropriate methodology. The question is always, how can we apply this evidence into osteopathic care specifically for these patients? Because two main things that have been highlighted regarding methodology is those studies, they did not include the specificities of non-pharmacological interventions, and they did not include the specificities of osteopathic principles and practices. So luckily, this is something that has been done recently. So I have been co-authoring this paper and designed it with two friends and colleagues, Laurent and Guillaume. The study that was published this year in the JAMA Internal Medicine. And so the design, this is an RCT with 400 patients, and it was designed 10 years ago. So just before moving to Kirksville 10 years ago. And that was published, so like I said, early this year. And what we have found, we have been very lucky to work with Dr. Isabelle Boutron, who is a specialist in non-pharmacological intervention methodology. So with her help, we designed a very strong methodology to evaluate the effectiveness of osteopathic manipulative treatment based on the diagnosis of somatic dysfunction among these chronic pain population. So each word, it has to be, I have chosen each word very carefully, because sadly here in France, there was a kind of confusion between the results. So what we have found is that there's a statistical significant difference between OMT and sham OMT. We used light touch, but this difference was not clinically relevant. We used the Quebec Back Pain Disability Index, and in order to have a clinically relevant difference, we need to observe a difference of 20 points. And we observed a statistically difference of 7 points. So to put it very simply, patients with chronic pain can't make the difference between what we osteopaths call a sham procedure and between what we osteopaths call a real procedure. So that is really challenge that was clearly, this is challenging these body-centered models only based on the somatic dysfunction title. So here in France, it was kind of a revolution, and then probably I would say yes. And last year I've been lucky to read this book from Thomas Kuhn, The Structure of Scientific Revolution, because we can say that this is absolutely normal in science to have an evolution of different models. And the problem, or at least probably what is currently occurring in the osteopathic profession, is this is something new. I don't think we already had to challenge our different models. And clearly, at least for chronic pain patients, this body-centered model of somatic dysfunction is kind of model crisis, and we need a revolution of model, something that is probably more person-centered rather than body-centered, exactly like the current osteopathic principle, the last revision in 2002, as highlighted. So we need this is not because it's not because we are challenging models that it's everything is wrong. It has helped a lot of patients. It continues to help a lot of patients. The only thing is who we want to interact with. If we only want to interact with osteopaths, it's okay. We can talk about somatic dysfunction. Everybody can understand exactly. But if you want to interact with medical doctors, with other scientists, here this is challenging because of this evidence is available for everyone. In this editorial that was published last year by the board of trustee of this foundation. So I was co-authoring this editorial that was written by George Esteves. We have put all the current models that could be used to describe what we do with patients in osteopathic care. So simply, we think that based on the current available evidence, we certainly have much more better models to describe what we do as osteopaths than the body-centered models. If we have a look at what we call the contextual factors, this is something very interesting to understand what I'm going to say lately is when I received my training in the UK, the way I've been teaching in the UK and in France for years were mainly the therapeutic outcome in osteopathy mainly relied on the treatment, on the manual treatment. And obviously, we knew that there was the importance of relationship between patient and practitioners, but we forgot a lot of things. And this paper written by Testa and Rossettini, two physios, Italian physio, they said there are 5 components that can be that are implied during treatment. So obviously the manual components, patient characteristic, clinician characteristic, these relationships, and healthcare setting. So the difference is that we certainly in osteopathy have put a lot of emphasis on the treatment component, the manual component of the treatment, and we probably have overlooked all those non-manual components. This review that was published by Michael Menke, he was a colleague of you, is that those contextual effects are 80% of acute pain and 2/3 of chronic pain. So this is something that was new to me to realize that the same manipulation, the same specific effect of manual therapy can be amplified or can be diminished depending on the contextual effect. If we build a positive or if we build a negative contextual effects. So basically this Testa and Rossettini paper is very interesting. There's a lot of recommendation on how to promote positive contextual effects in the clinical setting, the way we talk to patients, etc. So basically, it's just we just need to shift and to probably to focus more on the contextual effects and rather than the specific effects of manipulation. So this was clearly challenging, and obviously we were in the eye of the storm early this year after the publication, because a lot of colleagues and MDs and in the media, they say, well, osteopathy works no more than placebo. No, obviously there's a lot of this. It's very important to stress out the impact of contextual effects, but this is exactly the same for all non-pharmacological intervention. Here on average, you can see at the bottom of this graph that the overall effects of contextual effects, whatever the treatment, whether acupuncture, whether non-steroidal anti-inflammatory drugs, it's 75%. So it's like, it's like manipulation. So we need to be aware of this. So this is a qualitative study that was published by Oliver Thompson, a former colleague from the UCO in London. And he interviewed a couple of osteopaths in the UK. And basically, he discovered that osteopaths can have three main different interpretations and how they perceive themselves as osteopaths. What's the role of the osteopath? So he described a practitioner-centered approach in osteopathy with focusing on the body excuse me. And there's a lot of emphasis on the manual component, and other osteopaths can see themselves as communicator or educator, depending on the level of patient involvement. So again, I'm not saying here that one is best than another as osteopath. I'm just stressing out that it is important to be aware of that, because some patients wants to be at certain period of time of their life will need a low level of involvement, and probably with chronic pain patient, we need to help them to become much more active and in their recovery. So here we have said this. We have with my friends, we have put this graph in order to summarize all what I've been said just previously. So OMT has been described mainly to interact with neurological factors and tissular factors. I mean, to improve joint movement, to release muscle spasms, to decrease central sensitization, to diminish pain. And this is clearly a view of osteopaths as a treater, and it's really based on the 1953 principles that are body-centered. What we need to understand now, it's probably if we include the psychosocial factors and the importance of the contextual factors, we will have to include patient management. And for us, it's probably more in line with the 2002 current principles, where osteopaths can see himself or herself as a communicator and educator. So, like I said, all those graphs and those theories are very nice for us as osteopaths. But if we want to focus on the most important for us, it means the patients, we can see this qualitative study again. So this is a friend, Giacomo Consorti from Italy, who published his qualitative review last year. And he just wanted to know what makes an osteopathic treatment effective from a patient's perspective. So here you can read the conclusion. So participants here in Italy, they say that osteopathy is a path of awareness. Well, I said it's both of body awareness that starts from an experience of pain, leads them to contact an osteopath, and ends with their experience of the unity of body, mind, spirit. So again, we have this osteopathic tenet that seems to be important, but is not defined. So what we have done is to start with a kind of this is our paper that was published 2 years ago, and I've been lucky to work with Jason Exton from the museum. What we wanted to know is, where does that come from, this body, mind, spirit paradigm in healthcare? Because if you have a look at the scientific evidence available, you will see that only 2 types of professions use this body, mind, spirit paradigm as a tenet. So we have the osteopathic profession and we have the shamanic profession. So it was kind of difficult to see all, at least for me, to understand exactly the roots. So what we have found and what we have described is that Andrew Taylor Still interacted with the Native American tribe, the Shawnee, while he was living with his family in the Wakarusa mission, which is close to Kansas City. And he was considered what we call an Okonetowa. It's the Shawnee word for doctor. So Still himself was considered as a traditional healer by the Native American Indians. So in the museum, if you go to the museum, I've been lucky to see his carpet. He was treating his patients in osteopathy using his Navajo carpet. So again, I'm not an historian. I'm just a clinician, and I just wanted to understand this heritage, this legacy. So clearly, this belongs to the museum, but our past shapes our present, and our present shapes our future. So what we need probably to understand is that there's a combination probably of traditional medicine practices and Western practices. There's a combination probably in the current osteopathic manipulative techniques and the way we approach patients. And again, it was probably easier for me with my 2 different passports to understand what they meant regarding those traditional medicine and what they meant regarding the Western practices. And this is clearly very important because our current models of practice delineate the future scope of practices. Because if the profession wants to only focus on treating musculoskeletal pain, there's a lot of other people already doing the same job and treating the same patients. And if they use the same level of the same evidence available, at the end of the day, it looks like they will do the same. So, and clearly, for example, in the UK, there's a strong way pushing to merge this different type of profession. Why is there really a need to have different professions if we treat the same patient with the same techniques and with the same evidence? Clearly, I don't think this is the case, at least for osteopathy, because of this body, mind, spirit osteopathic tenet. This is clearly a distinction for us, and there's a lot of current practices that lacks of scientific evidence that could be, I would say, more easily described and incorporated into osteopathic practices should we make a wise use of this osteopathic tenet. So just a quick thing about those Native American principles. They see, again, this is not my area of interest as a professional. Because we are of our different papers, I've been contacted by a colleague in Argentina, and he's doing I think a PhD in anthropology, and he's studying exactly the interaction between Still and the Native Americans. So he has the methodology to evaluate this, and in the future, he will probably be much more appropriate than me to describe exactly the link. What we want to point out is that the Native American, they consider each person as interaction of body, mind, spirit, and emotion. So this is clearly osteopathic principles and practices for us are really at the border between allopathic medicine, Western scientific way of thinking, and the more traditional and complementary alternative medicine border. So in this paper, in this table, we've set 3 different columns with the Western principle on the right and the traditional principle on the left and the osteopathic principle in the middle. And sometimes we osteopaths are more using Western principles, and sometimes we are using more traditional principles. And the good news is that there's a lot of models, current models, especially neuroscience models, that have been used recently to describe those traditional principles. So that's really the basis of our work here in France and within the foundation, is that maybe we should start to use those neuroscience models that are currently used to describe traditional medicines. Those models will probably be much more appropriate to describe what we do as osteopaths compared to those body-centered models using somatic dysfunction. So again, maybe it's another revolution. This time, I would say revolution is when we go back to the start. So this is, for us, this is really funny because this is, we're going back to the roots of osteopathic medicine, back to the roots of the interaction between Andrew Taylor Stills and the Native American, because probably this body, mind, spirit, emotion, at least for us, is encompassing a lot of practices that could be described thanks to the current available evidence in neuroscience models. So I'm going to just give you 2 different examples for the non-manual approaches in osteopathic care and for the manual approaches in osteopathic care that could be developed based on this body, mind, spirit, osteopathic tenet. So first, if you're okay, we can have a look at these biopsychosocial spiritual approaches. We all know what spirituality is. So there's a lot of description here. And again, depending on the context, for example, here in France, we have a clear distinction between what remains from the personal domain and what remains from the public domain. So spirituality and religion clearly belongs to the personal domain. And for us, it has nothing to do in an osteopathic consultation. So the spirit component, what I'm going to say is very important. The spirit component of this body, mind, spirit osteopathic tenets, we have described it as the spiritual dimension in healthcare, which is different than spirituality. We don't need to work with spirituality. I don't think this is our duty as osteopaths or as osteopathic physician. However, the spiritual dimension in healthcare, you can have a look that there's an increase in the number of publications assessing this component of each person. So this spiritual dimension in healthcare is very important because it has direct and indirect links with physical health. One thing is what we can define this dimension as the tendency to make sense of relationship with dimension that transcend oneself. The concept of oneness, it means the concept of belonging to something that is bigger than ourselves. You can call it whatever you want, so it's just different belief. But we know that the people who have this kind of belief, they have better quality of life, they have much more healthy, they have less disease, they have less chronic pain, less addiction. So this may be an important component of the osteopathic visit in order to investigate this theoretical model, for example. So like we said, the spiritual dimension in healthcare can directly and indirectly have positive impact on mental health, on social support, so belonging to a community, especially in this time of COVID crisis. Those people are get more support and get less stress, and so less impact, negative impact on stress on the physical body. So how can we incorporate that in practice for osteopathic care? So the first who proposed to incorporate this spiritual dimension in healthcare in osteopathic practice was an English osteopath, Deborah Spies, who published a paper 3 years ago. And she defined spirituality, the spiritual component within the biopsychosocial model, as the meaning and purpose. So what we have done lately, that was our first paper that I've been lucky to publish with 2 doctors, so Jerry Parodi and Francesco Ceritelli. So that was our first paper on this topic. And we wanted to refine this biopsychosocial model for musculoskeletal practice by introducing religion and spirituality dimensions into the clinical scenario. So here we proposed a couple of, we give clear definition, and we give different possibilities on how to incorporate this in order to help patients to understand better what they're going through. Now, if we can have a look at more manual perspective of this, on how this body, mind, spirit osteopathic tenet could be applied, we can have a look at those interoceptive manual approaches in osteopathic care. Again, first, a couple of definition. So if you remember the qualitative study by Giacomo Consorti said, his conclusion was that osteopathy is a path of awareness, of body awareness. And body awareness is the combination, the constant combination of 3 different types of information arising to the brain: exteroception, proprioception, interoception. Interoception being the experience of having a body, proprioception being the experience of where I am in space, and exteroception being the experience from which I perceive the world. So other Italians worked on this theoretical aspect, and Giandomenico D'Alessandro proposed a model for an interoceptive model for osteopathic care, where they describe the specific type of manual approaches, prolonged light touch without inducing movement. This very specific type of touch is stimulating specific receptors that are increasing interoception. And for us, it began it was becoming more and more interesting, because we could see, for example, cranial techniques, visceral techniques, myofascial techniques, as we could, in our hypothesis, we describe those different types of techniques that are currently body-centered, because we describe these techniques based on the location of the body of where we apply the technique. We would like to describe those techniques more based on what is the main brain network that is stimulated when we use techniques. So those interoceptive techniques maybe probably better to describe if we want to move on to the body-centered models. In this graph, I just want to describe two things. Again, this graph, so the Kinefin model, this paper was published by Christian Lunghi and Francesca Baroni in the, it was the GAOA at that period of time. Now is the Journal of Osteopathic Medicine in the US. So they describe 4 different scenarios for osteopathic care, where the osteopaths can use different, can make different actions. So the interesting thing is that on the right part of this graph, you can see the analytical system. For us, the way I have interpreted that is that it's more the Western way of seeing things, of evaluating and treating a body. And the left part is the intuitive system based on pattern recognition that is very likely to a more traditional perspective. So if we have a look at the top, at the bottom left part, it's a chaotic domain. So the osteopath act, perceive, and respond at the same time. And here they describe the interoceptive approach. So because this was very fascinating, I have asked them to join us, and we have been lucky to update this graph that I'm going to show you in a couple of minutes. So if we describe these those interoceptive manual approaches, some questions are arising. So again, our hypothesis or revolution of model is we could start to describe those techniques based on the main brain network that is stimulated, rather than the location of the body where we apply techniques. The probable origin lies in traditional medicine. And again, this is important because we have current models in neuroscience, in the neuroscience of bodily perceptions that can be used to describe this type of techniques. In this type of techniques, the attention of the practitioner seems very important, and the main challenge was how to make visible what is invisible. Because the first time I saw my teacher treating patients applying cranial technique, there was absolutely nothing. You know, you have some patients lying down, and a practitioner with a gentle touch over the skull, eyes closed, and say, I can feel this, I can feel that, and you have to trust. And as a scientist, it's quite difficult to understand, is this something, really something happening right now? And if this is something, it is relevant for this patient, it is going to help him or not. So that was the main challenge, how to make visible the invisible. And then this paper came out. So that was published 4 years ago. And this is part of the Francesco Ceritelli's PhD in neuroscience. And this piece of work is really astonishing, because for the first time, he put 40 patients into functional MRI, 20 patients in each group. One group with patients applying light touch without inducing joint movement, so what we call interoceptive approaches at the ankles. And so for each patient, they receive exactly the same type of mechanical stimulation, the same OMT. In one group, osteopaths were the attention was focused on the technique, on the anatomy, exactly like we have been taught. On the other group, their attention was distracted by random sounds in headphones, and he could see differences and some brain network occurring in the group of patients focusing on what they do compared to osteopaths where attention was distracted. So for the first time, we could see that something is really happening with this type of light touch. So another interesting thing is that literature review from Van Elk and Alleman, and I've put spiritual into brackets because in his line of research is absolutely fantastic, because if you are interested, you can have a look. He recorded a TEDx on neuro enchantment, and basically describe his work. He's from the Amsterdam University in the Netherlands, and I have been lucky to have a couple of chat with him regarding his area, and he was really surprised that his work could have some interest in the manual therapy field. So, and I explain why, and I'm going to explain to you why, because what he found, he described what he called the God's helmet. So a specific helmet stimulating certain area of the brain, and literally patients, they describe seeing angels and demons. Seeing that, so spiritual experiences for us, for him and for me, is more a psychophysiological experience, because they can reproduce it. And once you start to describe, once you start to reproduce, you are doing science. You are not doing any belief or any strange things. So basically in his models, the differential weighting of interoceptive versus exteroceptive signal was able to reproduce this type of experiences. For example, I was very surprised to read that the out-of-body experiences, something that could be weird, it can reproduce it by stimulating the auditory nerve. So again, so this is opening a new area of research, especially if we consider that with what we call currently cranial visceral myofascial technique, we can have an impact on interoceptions. So if we have a look at the current models to use to describe traditional medicine, so basically they describe two channels. One is called the perceptual cognitive symbolic, and this is a typical Western scientific thinking. And again, it's like the right part of the Kinefin model. It's really the analysis. So if we have a look, if we want to put it into context for osteopathic care, is the way we, is a passive examination, active examination, range of mobility, and we apply clinical guidelines. So it's more an analytic way of evaluating and interpreting signs and symptoms. On the other side, you have more the direct intuitive non-local channel. It's usually used in non-ordinary traditional state of consciousness with a direct experience without subject-object division. So this part is more related to the left part of the Kinefin model, that is more related to traditional principles, and where we work with more intuitive approaches, with more the pattern recognition approaches. So what they have in common is that those changes in brain connectivity induce transient changes in perception of the world and interaction with the environment. So what I would say personally, the way I perceive my job as an osteopath right now is I'm helping my patients to perceive their body differently, to interpret their signs and symptoms differently, rather than just searching and treating somatic dysfunction. So I've put this table again. So that was previously to discuss the non-manual component of osteopathic care, but that's exactly the same for this manual component of osteopathic care. We all know colleagues that have a more Western approach, using techniques to improve range of motion and decrease pain. And that's okay. For example, my colleagues in the UK, 97% of patients visit an osteopath because they have musculoskeletal pain. This is okay. And we all know colleagues who they use manual techniques to improve overall well-being. So one question that I ask in each of the lectures I'm giving is, what do you do when you have patients who come to visit you who doesn't have any symptoms, no physical symptoms? And sometimes I have colleagues who say, but no physical symptoms, so I can't do anything. I prefer to focus on patients who have more, who have physical symptoms and who have chronic pain, and that's okay. And I have other colleagues, and I meet other colleagues who have a lot of patients without symptoms, and they treat that. And having a flexible musculoskeletal system is part of their overall well-being. So what we need to understand is like I said at the beginning, is that what's the underlying social-cultural assumption. So the decreasing symptoms, being symptoms-free, is more a Western belief system. And once living in harmony with the environment, within the community, is more a traditional perspective. So in the osteopathic profession, you can correct me after if I'm wrong, is the only profession, the manual profession, who has this larger scope of practice. So one interesting thing that I'd like to emphasize with you is sometimes it looks like magic. You know, what's going on, and this is something that comes from outside, that's coming inside. This is not the case. We all have the same brain, but it's shaped differently, like I said, based on our different sociocultural assumption and based on all the training. We all have this type of perception, but sometimes we don't have enough knowledge and we don't know how to interpret them. So basically what we want to do is, if I take this example, is if you have a look at this, you can see just black and white dots. So you can receive information that you can't interpret. And then we can put colors, and you can see a woman with a horse, put the colors. And if I put the exact same image, I'm sure you can still recognize the horse and the woman. So that's the way our brain works. Once he can interpret things, this is kind of forever. So again, there's a lot of things that we can perceive when we touch a patient, especially in those when we use this type of interoceptive manual approaches, but sometimes we don't have enough information on how we can interpret them and how we can use them in clinical care. So I'm going to wrap up this presentation and discuss with you future perspectives. That's the topic of our last paper that was published last June. So very recently, where with colleagues, we proposed a roadmap to investigate the clinical relevance of the body-mind osteopathic tenet. So I've presented you a lot of materials that we are using in our education, that we have presented in various congresses. But it's based on our experience or understanding. So, but if we want to do that properly using science, we need to have a structured way in order to investigate the clinical relevance of this osteopathic tenet. So, so I left the US 7 years ago, so I'm not sure about exactly what's your context is right now, but I can tell you what's the context is here in Europe. If we can summarize based on the best available evidence, what osteopathic care represent here in Europe. So the purpose is to reassure and reduce fear, reduce anxiety by explaining patients' symptoms. That's the biopsychosocial approach. We need to address inappropriate beliefs and behaviors. We need to educate patients on how to interpret these symptoms, pain, and we are promoting confidence in movement and we need to encourage an increased activity. So that's common to a lot of manual professions. So clearly here in Europe, the osteopathic professional identity is challenged. What I'm just going to say, this is the exact definition of orthopedic manual physical therapy. This profession is driven by the available scientific and clinical evidence and the biopsychosocial framework of each individual patient. So the question here is, here in Europe, because we are not physicians like in the US, what's contemporary osteopathic care? What's the real difference? So, like I said, our difference for us is for us, when I say us, is my friends and colleagues are sharing my thought on this tenet, is that we stress out that the osteopathic profession is the only one who can help patients interpret the signs and symptoms in two different environments. We have described on the right corner, this is the updated Kinefin model that we've published last June. In the symptom-oriented scenario with the primarily Western sociocultural health assumption. So this right part, I would say, is common to physiotherapists, to chiropractors, to medical doctors. The left part for us, it's specific to osteopathic techniques, to osteopathic care. If we are more in non-symptom oriented scenario and the primarily complementary and alternative sociocultural health assumptions. Just what does that mean exactly? One key feature of those CAM sociocultural assumption is the belief that the body has the ability to as self-healing capacities. So this is something that we have been taught in osteopathic care since day one of our studies. So it comes from this traditional belief, this traditional root. So again, we can see clearly a line of research that should be promoted, because we now have strongest neuroscience models that could be used to investigate the clinical relevance of this tenet. So what we have proposed in our last paper is we have used these guidelines, these Medical Research Council guidelines, to develop and evaluate complex intervention. Complex intervention means non-pharmacological intervention. So we have described 4 steps: development, feasibility, evaluation, implementation. So we have just put here the first step, identifying the evidence base for this tenet, because like I said, there's a lot of material that is already published in this body, mind, spirit, osteopathic, or body, mind, spirit approach in other professions. Maybe there's some relevance. One very important thing is that we are, and I am doing that as well, is I'm making probably a lot of assumptions regarding patients, but we don't have any clear data regarding patients. What are their main belief system? We assume they want to receive manipulation of osteopathic manipulative treatment, but probably they are looking for different things, and they may search this OMT within a Western scenario or within a CAM scenario. So this is something that should be clarified, that should be defined. So we have proposed a logical and step, and we need to build strong foundation to start investigating the clinical relevance of this tenet. So I'd like to thank all those people who have been crazy enough to help me over those past 2 years. So my team here at BMS Formation, and my colleagues, the Board of Trustees of the COM Collaboration Foundation, Francesca and Christian from the ICOM in Malta, Bertrand Bourriot, the Dean of CESO Paris, Dr. Zegarra-Parodi from UCO, and I've met a lot of traditional healers from the Lakota, the Shawnee, and the Shipibo tribes. That was more my personal life, but discussing with them was very helpful. It helped me a lot to understand exactly what they meant and how osteopathic medicine, the way we view osteopathy as at the border between traditional and Western practices, was very helpful. And obviously, I'd like to thank you all my colleagues at ATSU, Brian, Deborah, who was very helpful in revising our different papers and including this presentation, Jason, who gave us a lot of materials from the museum, and all the people from DO-Touch.NET. So thank you very much for your attention. So again, I know there's a lot of materials. I can send you the different papers where we have been. We can have more time and to think about this. And you got my emails, you got Brian emails. If you have any question, I'll be happy to answer. So thank you again, and let's start the Q&A session.
Thank you, Rafael.
Go ahead, James.
Sorry. Thank you, Rafael. We're running a little long today. I believe that Brian Degenhardt has a few comments to make, and what we may need to do is put the Q&A questions on the discussion forum on the DO-Touch.NET website, and then Rafael or anyone else who wants to discuss those questions can do so there. So, Brian, you're muted.
Thank you, Jane. First of all, Rafael, I want to thank you for an excellent presentation. This has often been a difficult area for us to talk about, not within the clinical realm, but certainly within a scientific realm. And you did just an excellent job in getting us up to date on that. I just want to make 3 quick points to look at spirituality from that Western model. In the 1990s, there was a group of scientists who actually defined spirituality in a way that I have found very effective for me, both as a clinician as well as a researcher. And they define spirituality as one's connectedness to who they are, to the people around them, and to a universal entity, however that person defines it. And so Rafael spoke very much on defining it in that third category, but it also, when one's talking about one's personal spirituality, it's also their sense of connectedness to who they are and to the people around them. And if you think about that, and the current issues that are facing humanity throughout the world, I could argue that we are looking at a pandemic of spiritual diseases, because there is just rampant problems in one's connectedness to who they are, to the people around them, and to any type of universal sense of energy or unifying characteristics. In other areas, whether it's physical, mental, emotional, we have a variety of tools to try to assess them clinically. What are the tools that might be available to assess spirituality? And I would just like you to think about, if you use that definition of spirituality, anything where there is negativity about their connectedness to who they are, about their connectedness to the support structure and the people around them, or to some just, denial, or just anything in regards to a universal type of source of life. I would say that those are all indications that there could be a spiritual disease going on. And there is one tool called the Adverse Childhood Events Questionnaire. It's called the ACEs. And that questionnaire, many times in Western world, we think spiritual care is something that's related with end of life issues. I would argue that spirituality is probably, the traumas of spirituality probably occurs very early on in life, and then are sustained throughout a whole pattern of life. And this Adverse Childhood Events Questionnaire really gives us a handle on beginning to identify people that may be struggling with spiritual issues. So those are my comments. Once again, Rafael, thank you so much for yours today.
Thank you, Brian.
Thank you all so much for joining us. Like Jane had mentioned, we'd gone over by a few minutes. So we're actually going to take all of the Q&A and we're going to put them on the website. And I will send out an email later to all of you, later this afternoon, to all of you, to let you know it's available. And then we can continue the discussion there. Thank you all for joining us. And thank you, Rafael and Dr. Degenhardt.
Thank you again for the invitation. Goodbye.